Good morning, everyone. So today we'll be discussing about a major topic, which is melanoma. So about the introduction about the topic. So a malignant tumor arising from melanocytes, that is what is called melanoma. And it is said that it accounts for 4% of all skin cancers, but 75% of all skin cancer deaths. The mean age of diagnosis is relatively young at around 52 years old. But the incidence of the disease increases with increasing age, especially in men. So we know that there are different layers of human skin. We have epidermis on top, then we have dermis below, then we have hypodermis below that. In this figure, we can see that epidermis, dermis, hypodermis are the main three layers of skin. In this, epidermis has got 5 layers. Okay, they are stratum corneum on top, then stratum lucidum, which is seen only in palms and soles. Then we have stratum granulosum, then we have stratum spinosum, and then we have stratum basale or the basal layer. The stratum basale is where usually the melanocytes are present. So a tumor arising from these melanocytes is called melanoma. About 75 to 80% of cutaneous melanomas originate from normal skin. Therefore, only 20 to 25% of melanomas develop from cutaneous melanocytic nevi. Now, what are the risk factors to get melanoma? The most important risk factor is sun exposure, that is UV radiation exposure. That's the most important risk factor. Then we have blistering sunburns at any time in life, intermittent or sporadic high level exposure, excessive chronic exposure to sunlight, exposure to PUVA and UVB radiations, and also phenotypic characteristics, that is, people who belong to Fitzpatrick skin type 1 and 2 mainly. That is, those people who have fair skin and they have the inability to tan and they have tendency to sunburn or freckle formation. These are the Fitzpatrick 1 and 2 people. They have blue or green eyes and red or blonde hair. So this photo is of Fitzpatrick type 1. She's belonging to that type. She's having that kind of red hair and green eyes and all. These people will have less tendency to tan. They won't tan, but they can develop sunburn, freckle, and they have more risk to develop melanoma. Then another risk factor is large congenital nevus like this. This photo is a case of large congenital nevus that has high risk factor to develop into melanoma. Then numerous typical nevi, more than 100 in adults, more than 50 in children, and or more atypical nevus. So these are some other risk factors. Then history of prior melanoma, family history of melanoma, mutation in P16, BRAF or MC1R, as well as xeroderma pigmentosum, immune suppression. These are some of the risk factors to develop malignant melanoma, So here is a photo of xeroderma pigmentosum. This child you can see is called xeroderma pigmentosum, which is a DNA repair problem occurring because of problem or a defective DNA repair mechanism by which these kids will be more sensitive to sun. They can develop skin lesions like this. Then below that figure, we can see a typical nevi. Okay, on the right side, we can see atypical mole. So how do you understand whether it's a typical mole and atypical mole? Any mole which is having an irregular border or an unusual shape, okay, or diameter is more than 6 mm. Okay, usually the normal mole is less than 5 mm, less than 6 mm. It will be more than that in a typical mole. There will be asymmetry, that one part of mole will be different from the other part. The symmetry will be different. Okay. Then two or more shades of color. In a single nevi, single mole itself, there are different types of colors. Like you can see in this photo, there's black, brown, there's red. So there are different shades of colors. There's another feature in typical mole. And another feature is a flat and bumpy surface. Okay. So normal typical mole doesn't have, it usually doesn't have any bumpy surface, usually towards the surface. Okay, it doesn't have any different color. It's usually symmetrical on both sides or all the sides, and usually less than 6 mm diameter, and the border is usually regular. But atypical mole has everything different, like I said. So this kind of atypical mole or typical mole, but it is more than 100 in adults or more than 50 in children. These are the risk factors to develop melanoma. Other than that, we already discussed seronegative pigmentosum, family history, immunosuppression. Then we have Fitzpatrick types 1 and 2, excess exposure to sunlight, and previous exposure to UV radiation. Then, what are the most common sites to develop this melanoma? In men, upper back and trunk. In women, lower legs and then trunk. And older patient, face, then scalp, then neck and then scalp and then ears. So men usually come on their upper back and trunk, they'll have problem. Women will have lower leg, then trunk. Older people mainly on the upper region, like face, scalp, and all. These are most common sites to develop melanoma. Histopathology. Histopathology is a gold standard for diagnosis, and we should look for cytological and architectural features. Cytological atypia, that is, there is cellular enlargement, there's nuclear enlargement, nuclear pleomorphism, hyperchromasia of nuclei, nucleolar variability, presence of mitosis in deep dermis. Okay, so basically the cell, okay, in the melanoma cell is enlarged, or nucleus inside the cell is enlarged, or nucleus will show different types of shape and size, like that pleomorphism is seen, or inside the nucleus the chromatin material is intense or dense, hyperchromasia, or nucleoli inside it has variability, or in deep dermis there's mitosis and mitotic figure C. These are what we look for in cytological atypia. This is cytological atypia seen in histopath. Architectural features are asymmetry, poor circumscription. Their cells at the edge of lesion tend to be small, single, scattered, large size, more than 5 to 6 mm. These are architectural features. The different subtypes of melanoma have different histopathology also. So we have different subtype melanoma, we'll come to that now. Different subtype will have different histopathology features also. This helps us to diagnose it even easily. Okay, so this is a histopath is a gold standard for diagnosis. So we look for cytological atypia and architectural features. So what are subtypes of melanoma? First, we have superficial spreading melanoma, SSM. The most common subtype is SSM. 70% of all cutaneous melanomas come under this. The most common site in women, it's the lower extremities. In men, it's upper back. It's most commonly associated with pre-existing nevi. It may appear dark brown to black, blue-gray, pink, red, and gray-white in color. DDs are atypical or common nevus, basal cell carcinoma, seborrheic keratosis. The pathology of SSM, where it shows an upward scatter of large atypical melanocytes with pale cytoplasm in the epidermis. There are nests of various sizes arranged irregularly along the basal layer and in the dermis. There is irregular pigmentation of the lesion and mitosis. So here we can see that there are a lot of atypical melanocytes with pale cytoplasm inside the epidermis, and a lot of nests of cells are seen along the basal layer. Next type is the nodular melanoma. The second most common type melanoma is the nodular type, which is constituting 15-30% of all melanomas. It's most commonly seen on the trunk. It undergoes rapid evolution, that is in weeks to months, and it appears as a uniformly dark blue-black or a bluish-red raised lesion. But 5% are amelanotic. Like you can see in the photo, it's a dark blue-black colored lesion. And but 5% will not be amelanotic. There won't be any color in that. Okay, so the DDs of this being basal cell carcinoma, pyogenic granuloma, hemangioma, and common nevus. Pathology nodular type. The nodular melanoma shows aggregates of atypical melanocytes in the dermis with some extension into epidermis directly overlying the tumor. So here we can see in the pathology slide, we can see a lot of atypical melanocytes inside the dermis. It's filling the dermis. Along with that, they're also extending towards the epidermis, overlying tumor. So they're basically the tumor is pushing the epidermis up. Okay, that is a nodular form is coming. The dermal component usually shows a compact nodular aggregate of large melanocytes with large nuclei and prominent nucleoli. Next is lentigo-maligna and lentigo-maligna melanoma, LM and LMM. It constitutes 10-15% of cutaneous melanomas. It occurs mainly in 7 to 8 decades of life. Most common sites are face, neck, scalp, ears, and neck. It appears as flat, slowly enlarging, brown, freckle-like macule with irregular shape and differing shades of brown and tan. DDs are pigmented active keratosis, flat seborrheic superficial pigmented BCC. So this is the next type. In 10-50% is LMM or LM, mainly seen old age, mainly seen on the face. It appear more like freckle with a flat macule-like lesion, brown color. Pathology-wise, it's characterized by proliferation of atypical melanocytes, predominantly along the dermal epidermal junction. So along the DAJ or dermal junction, we can see a lot of atypical melanocytes. Upward scalp tumors may occur and downward extension along hair follicle and sweat duct is also common. Next to acral lentiginous melanoma. It constitutes very less than 2 to 8% in melanomas in Caucasians, but it is the most common form in darker pigment individuals. So most commonly darker individuals we see acral type, acral lentiginous melanoma. It's more common in older population. Most common sites, like the name suggests, is seen in the acral or extremity, that is in the palm, sole, subungual locations. It appears brown, black is most common type, or tan or red variegations in color and irregular blotting. So since it's coming in palms and soles now, you think about DDs being plantar wart, hematoma, and onychomycosis. The pathology of acral type, it shows hyperkeratosis. Okay, there's hyperkeratosis, stratum corneum proliferated, and there is marked acanthosis and a proliferation of atypical melanocytes along the bases and sides of retinal ridges in a lentiginous pattern. The large atypical melanocytes show irregular nuclei and prominent nucleoli, and the cytoplasm is filled with melanin granules. You can see the cytoplasm of these cells are filled with melanin granules. That's why the color is coming like that. So there is diffuse hyperkeratosis and marked acanthosis. Next type is the desmoplastic melanoma, which is the most common type in 6 and 7 decades of life. Most common sites being head and neck. It appears as firm, sclerotic, or indurated, and they are usually amelanotic, that there is no color. It also shows perineural invasion, that is involved in nerves. Pathology-wise, you can say it shows spindle-shaped melanocytes between bundles of thickened collagen. So we can see a lot of spindle-shaped melanocytes inside between the collagen. It's visible. Typically, the overlying epidermis doesn't reveal any atypical melanocyte. Extension of spindle-shaped melanocytes around the dermal nerve is a common characteristic finding. We basically spindle-shaped melanocyte are seen between collagen. That's what we see in desmoplastic type. Next, mucosal melanoma. It develops the mucosal surface of the head and neck region, that is conjunctival, intranasal, oral, bulbar, urethral mucosa. It appears as a deeply pigmented, irregular lesion that sometimes presents with bleeding or as a mass lesion. Nevi melanoma is a rare lesion. It resembles benign nevi by histology. It clinically presents a tan papule or nodule, more often more than 1 centimeter in diameter on a young adult. So it may appear like a normal benign nevi seen in young adult. It's very rare. Next is Spitzer melanoma. Clinically and histologically, it resembles Spitz nevus. Now, other rare types are metaplastic melanoma, balloon cell melanoma, mixed cell melanoma. So those are the main clinical types of subtype melanoma. Next, let's talk about melanoma and pregnancy. The melanoma is the second most common cancer seen in women of childbearing age. It occurs due to elevation of endogenous hormones like estrogen and MSH, that is melanocytic stimulating hormone. But pregnancy doesn't increase the risk of developing melanoma. Treatment, we can do a surgery, including sentinel infant biopsy. Certain chemotherapy and immunotherapy are usually contraindicated in pregnancy. So surgery can be done. So it is the second most common cancer in women of reproductive age or childbearing age. Pediatric melanoma. It may occur most commonly without the classic predisposing factors, familial melanoma, congenital nevi, dysplastic nevi, and seroneuma pigmentosa. These factors are increasing age, UV exposure, and Caucasian background. That is pediatric melanomas in children. Now, how do you diagnose it? We can diagnose this. That's the subtype of melanoma. How do you diagnose melanoma? We have an ABCD checklist, which is A for asymmetry, That means one half of the lesion is not identical with the other half. The B is border. Border is irregular, scallop, drab or pole defined border. C is color. That is, there are different shades of color from one area to another difference. D is diameter, which is more than 6 mm. E is elevating or revolving, that is changing lesion. But these ABC will not be applicable for nodular type. So this is A, asymmetry. See, we can see normal, there is symmetry of both the half lesion. In melanoma, there is asymmetry. See, both the half lesion are different from each other. Borders are even normally, borders are irregular in melanoma. Color, same color throughout the surface of the lesion normally. Different colors seen in melanoma. Diameter is less than, like I said, 6 mm. 6 mm, well, more 6 mm melanoma. And evolving, usually remain like that, but in melanoma, it will change. It will evolve or it will change on its surface appearance with time. That is the ABCD checklist for melanoma. It's very important. It shows ugly duckling sign, that is, there is change in appearance symptoms over time or difference from the lesion, other lesions. That is what we see melanoma. Itching, ulceration, bleeding tenderness can also occur. Development of a new pigmented lesion, especially more than 40 years old, and on an anatomic site without similar lesions, should raise suspicion. Physical examination. You should examine skin properly in optimal lighting and observe scalp, oral mucosa, groin, buttocks, palms, and toes. You should look for number of nevi, both typical and atypical, and distribution. You should ask for family or personal history of melanoma, skin type, UV history, previous biopsy, atypical nevi. Look for regional lymphadenopathy, and dermoscopy can be done for better evaluation. Immunohistochemistry. It shows positive for S100 protein, HMB45, and it also shows positive for vimentin, melan A, or MART1. Now we have the TNM classification. TNM classification we have stage 0 means the disease in situ. In situ disease means it is remaining confined to the epidermis. The tumor is not going below epidermis. Okay, that's stage 0. Stage 1 and 2 is localized disease. That stage 1 means the tumor is less than 1 mm in size without ulceration. Stage 2 means tumor is 1 to 4 mm in size with ulceration. Tumor is less than 1 mm, very small, there's small ulceration. Stage 1. Stage 2 means tumor is a little bigger, it's 1 to 4 mm, but and also it's ulceration. Okay. Stage 3 is regional disease. Basically, the tumor is extending towards the dermis, and it's also extending towards the lymphatic channel, spreading towards the lymph node. That is, regional disease has happened at stage 3. Stage 4 is distal metastatic disease. Disease is spread to other parts of the body like lung, liver, etc. That distal metastatic disease. That is like the end stage. That is severe stage, a bad stage, prognosis very bad in that condition. So these are the 4 stages of TNM classification of melanoma. Now, what are prognostic factors? Age. Age is more severe with increasing age, like in any cancer. Gender, it's more severe in men. Anatomic site. It's not a strong independent prognostic factor in melanoma, but said that those on the limbs have better prognosis than those on the head and neck. So those on limbs are better prognosis compared to that coming on head and neck region. That's anatomic site, age, gender is some of the prognostic factors in melanoma. The prognostic factors in micro stage. We have something of breast thickness. So tumor thickness can be checked by breast thickness, which is the thickness of the tumor measured from the top of the granular layer to the lowest invasive tumor cell. The single most important risk factor of melanoma. So here we can see breast thickness. So it is measured from the top of the granular layer to the lowest tumor cell, lowest invasive tumor cell. That thickness is called breast thickness. Is the most important risk factor of melanoma. Second is ulceration, which shows worse prognosis. Third, mitotic rate. More mitosis, more it's worse. Angiolymphatic invasion has worse prognosis. That when the blood vessel and lymphatic is involved, worse prognosis. Microscopic satellite. That if it's present beyond the tumor margin means worse prognosis. Regression also means worse prognosis. So, more thickness of tumor, ulceration, increased mitosis, angiolymphatic invasion, microscope satellite regression, all denote worse prognosis. So these are the what microstaging, prognostic factor, microstaging. The prognostic factor is regional metastasis. It is said that status of regional lymph nodes is the most powerful prognostic factor of survival melanoma. Presence of regional lymph node metastasis pretends a worse prognosis. So it is very prognostic that when lymph nodes are involved, the prognosis is bad. A prognostic factor is distal metastasis. The site of metastasis is an important prognostic factor. Distal mets have a relatively poorer prognosis than non-distal sites, the skin, subcutaneous tissue, and distal lymph node. So if the organs are involved, it is worse prognosis. Other variables are number of metastatic sites and surgical resectability. That's what prognostic factor distal metastasis. He also Clark's level invasion, which is a robust indicator of survival. Level 1 invasion means the melanoma is confined to epidermis. It is not coming below epidermis. Level 2 invasion means it is with or without expansion of papillodermis, but not filling it. So level 2 means it is involving the papillodermis, but it may not fill it. It may or may not fill it. But level 3 means it denotes filling. Filling of papillodermis definitely occurs level 3 invasion. Level 4 invasion means other than papillodermis, reticular dermis, that deep dermis will also be involved in level 4 invasion. Level 5 invasion means epidermis, dermis, everything is involved. Subcutaneous also, that is 7.5. Level 1 only epidermis. Level 2 part of papillodermis. Level 3 full of papillodermis involved. Level 4 reticular dermis also involved. Level 5 subcutaneous involved. These are Clark's level of invasion. This is a robust indicator of survival of melanoma. Treatment. Patient with lesions clinically suspicious for melanoma undergo prompt excisional biopsy with narrow margin. The recommended margin are 0.5 centimeter for in situ lesion. Like I said, those lesions that are confined epidermis, 1 centimeter for melanomas up to 1 mm thick, 1 to 2 centimeters, melanomas 1 to 4 mm thick. Like you can see it in figure, if it is 1 mm thick, we should take a margin of 1 centimeter thick. If the tumor is a little bigger, thicker, it's about 1 to 4 mm thick, we should take a margin 1 to 2 centimeters. But if it's even more thick, more than 4 mm thicker tumor means 2 to 3 centimeters margin we should take. Okay. Other factors which decide the margin includes anatomical location and histological type. These recommendations mainly be used for the superficial type of melanoma. In LM and ALM, that is in lentigomelanoma as well as in acral type, subclinical extension of the incident tumor commonly that's 0.5 centimeter, exceeding 0.5 centimeter, and asymptomatic growth is common. So that is why in such cases, asymmetrical standard margin may cause disservice to the patient. Because in LM and ALM and all, it's not like how you see it. There can be subclinical extension of tumor. Even if we think it's in situ tumor, there will be subclinical extension such that if we take only according to the size, thickness, it may not be correct. If we take margin, like we said before, we're taking 1 centimeter, if it's 1 mm thick, like that, follow that pattern. It will not be fair for LM and ALM because here subclinical extension is thick. So, because of which, what can happen is if we do that, it may result in positive lateral margin and difficult closure because excessive uninvolved skin was sacrificed. So, in this condition, what we are doing is we have to MOHS micrographic surgery, more micrographic surgery. In patients who are poor surgical candidates, topical imiquimod and radiotherapy may be utilized. Nail appendage melanoma is also common. In this condition, it may require amputation of a digit or skin grafting. MOHS can also be tried here also. Elective lymph node dissection, that is removal of lymph nodes that do not have a clinical involvement, may or may not be done. Sentinel node biopsy should be discussed with the patients whose melanomas are 1 mm or greater in thickness. It is considered for thinner lesions in patients who have ulceration, Clark level 4 or 5 invasion, regression, vertical growth phase, positive deep margin or initial biopsy. These are conditions that we consider. For in-transit metastasis, we can do surgical excision, interferon, IFM. Then we have hyperthermic lymph perfusion methods with melphalan, carbon dioxide laser ablation, intralesional BCG can also be given. Adjuvant therapy, most commonly we use interferon alpha 2B is given in patients with positive node or no negative melanoma, that is 4 mm thick, ulcerated, Clark cell 4 or 5. So adjuvant therapy can be given if the patient have positive lymph node, or they don't have positive lymph node, but still the tumor is very thick, 4 mm, or there's ulceration, or the invasion is involving dermis subcutis, that is Clark cell 4 or 5. In this condition, adjuvant therapy is given. Otherwise, not needed. So that's the main thing about it. Now I'll just summarize the whole thing so that you'll remember it better. So we have melanoma. It's actually a malignant tumor arises in melanocytes which are present in the basal cell layer or stratum basale of epidermis. Okay, we have different subtypes. So before that, these are some risk factors, like I said, risk factor 1 and 2. UV radiation, previous to melanoma, large nevi, families to melanoma, xeroderma pigmentosa. Most common sites may differ depending upon gender of the patient. And histopathology, histopathology is the most gold standard diagnosis, where we look for cytoid TPA and architectural features. There are different features, there are different subtypes, like superficial spreading melanoma, most common type, nodular melanoma, second most common type, lentigo maligna and lentigo maligna melanoma, third type. Then another type, achial lentiginous melanoma, desmoplastic melanoma, mucosal melanoma, nevoid melanoma, pixoid melanoma, and melanoma. These are the different subtypes. Now, we have melanoma different special situations like pregnancy and pediatric type. Pregnancy will happen without surgery. Then diagnosis, main thing is ABCD checklist. Basically, we should look for checklist. That is, we should look for asymmetry of lesion, the border, whether it's irregular, and color, whether the colors present up at the lesion, diameter as more than 6 mm or not, elevation, revolving lesion. These are the what we look for diagnosis. Ugly duckling sinus. Physical examination, like I said before, examine properly. Look how many typical, atypical nevi are there. Look for history of family UV exposure and all that. Look for lymphadenopathy. Immunohistochemistry can be done. TNM classification can be done. The prognostic factors are different prognosis. We have clinical prognostic factors like age, gender, anatomy, site. We have prognostic factors microstaging, like the breast law thickness, like I said before. Thickness on top of the annular layer to the lowest invasive cell. So next we have the prognostic factors in regional metastasis also. We have that distant metastasis. The Clark's level of invasion. That's the robust indicator in survival. Clark's level invasion. Okay, that we have. Now treatment wise, like I said before, it is depending upon the thickness of the tumor. It's 0.5 for those which are in the epidermis itself. Depending upon how thick it is, the margin also increases. 1 mm thick, 1 centimeter margin, 1 to 4 mm thick, 1 to 2 centimeter margin, more than 4 mm thick, 2 centimeters margin. That's how much we should take. And like we said, in LM and ALM, this we should do more microwave surgery because there might be subclinical extension which may not be evident in this condition, these conditions. So we should do more microwave surgery. Patients who have nail apparatus problem, better to do nail amputation or digit amputation and then skin grafting because it may spread. And the thing is, most microwave surgery we can try in these conditions also. But if the patients are poor candidates for surgery, like the very old people or they uncontrolled diabetes, any such kind of candidates, you can also try radiotherapy and topical enema. So you can do elective lymph node dissection. You can do a sentinel lymph node biopsy. Okay, it's mainly considered like if the conditions have ulceration, like very bad. We think that prognosis bad. Only these conditions we have it. Like this ulceration, there is 4 or 5 Clark's level of invasion, regression, vertical growth phase, and positive deep margin biopsy. It's a condition where we do it. Where we do sentinel lymph node biopsy. So adjuvant therapy, like I said before, it's given for patients who have positive lymph nodes or who do not have lymph nodes, but they have their tumor is thick, like 4 mm thick, or it is ulcerated, or there is Clark's level 4 or 5 of invasion. That is the tumor is involving deep dermis subcutaneous. That condition, or there is ulceration in such physical changes, or the tumor very thick, foramen thick. This condition, even if the lymph, we do not check the lymph node status in this condition, because this condition, even if the node is negative, we should give adjuvant therapy. And most commonly we use interferon alpha 2. Okay? And for in-transit metastasis, that we can also do surgical excision, or we can try carbon dioxide laser and also BCG. Those are the treatment methods. We should look for thickness. We can do more mammographic surgery. We can do topical imiquimod and radiotherapy. We can do amputation, skin grafting. We can do elective lymph node biopsy and sentinel lymph node biopsy. We can do surgical excision or carbon laser, and we can also try adjuvant chemotherapy. So that's all about melanoma. So you should be knowing everything, like you should be at least knowing things like what is melanoma and what are the risk factors to develop melanoma. Okay, so that's important, like what are the chances, which patients are more chance to develop melanoma. You should know the different subtypes of clinical features of melanoma. Okay, subtypes melanoma, and different subtypes have a different histopathology, which also you should be knowing. By whether we can confirm diagnosis, gold standard diagnosis. Then we have special features, how diagnose, ABCD checklist, physical examination, immunohistochemistry, TNM staging, prognostic factors from various areas, Clark's invasion treatment, also, like I said, different methods of treatment. That's all about it. Thank you so much.